Hello, everyone, and welcome to the latest episode, episode 18 of Techcyte's webinar series, Pioneers in Digital Diagnostics. I'm your host, Jacob Hicks, and I'm delighted today to be joined by a couple of physicians. I'll introduce them shortly. Today's webinar is titled Enhancing Organ Allocation Efficiency with AI-Assisted Kidney Pathology Assessment. I'm joined today by Dr. Tiffany Chen, Chief Medical Officer at Techcyte, and we also will be later joined by Dr. Jeff Campsen, a transplant surgeon, and I'll give a deeper introduction of him here in a little while when we join him. Today's webinar, we're really excited. I'll give a very brief introduction about Techcyte's AI and workflow platform, Techcyte Fusion. I'll help you all understand a bit about what that platform offers. And then we'll dive deep into organ donation, the challenges of current practices within this space, how the Techcyte solution helps meet some of those challenges, an academic study that has been performed and now published, and where things might head from here now that we have kidney pathology assessment, what other opportunities there are in this organ donation space. And then, as always, we'll have official dedicated time for question and answer. We do encourage you to put your comments or questions in the chat throughout the call. There might even be times we address them in real time, but for sure we will address them here at the end of the webinar. Really appreciate your engagement, and looks like we've got a lot of folks on. We appreciate the excitement today about this unique application. So first, a bit about Techcyte. Techcyte has been in business about 12 years. We were originally a technology transfer company out of the University of Utah and ARUP laboratories. We have built a world-class software as a service platform that automates and digitizes diagnostics across all laboratories in the medical or human space, veterinary, and environmental. We have staff, all the team members all over the world in over 20 US states and multiple countries. And our platform has been the means to providing diagnostic information and helping to make clinical decisions for over 6 million patients. We are deployed our SaaS platform in over 7,000 locations globally in many, many countries. Our solutions for medical are in both anatomic pathology and clinical pathology. We're the only platform in the world with solutions across tissue, liquid, cellular, smearable sample types. Our workflow and AI solutions help laboratories be more efficient, and it's designed to help them be more accurate as well in making clinical decisions to improve patient care. Now, to help us understand more about this problem, though, in the organ donation space, I'll turn the time to our board-certified anatomic pathologist, the Chief Medical Officer at Techcyte, Dr. Tiffany Chen. Tiffany?
Oh, thank you so much, Jacob. I actually see that Dr. Campsen is here, so I would love to get his take as our transplant surgeon who we've invited today for our presentation. Perhaps we can give a brief bio for him.
That'd be wonderful. Thank you. Dr. Campsen is on. Okay, so Dr. Jeff Campsen is the Medical Surgical Director of Donor Connect, an organ procurement organization that services the Intermountain region. He took that position on in 2024. This role, it places him at the forefront of organ donation and transplantation efforts throughout the Western US. He oversees the critical processes that save and enhance countless lives. I think most of us in our circle of influence are aware of someone either waiting for a kidney or liver or pancreas transplant or who have had one. And I just think about one colleague I had, the way it transformed and saved his life. It's just beautiful, mission-driven work. Dr. Campsen's career has included serving as a surgical director of pancreas, adult and pediatric kidney, and living donor transplantation at the University of Utah. He did that from 2011 to 2024. And at that time, he significantly advanced the transplant programs, improving outcomes and expanding access to life-saving procedures for patients across the region. Dr. Campsen really is a pioneer in the field of kidney pain. He specialized in autotransplantation of the kidney for loin pain hematuria syndrome, offering hope to patients with complex renal conditions. He's practiced at prestigious institutions, including the University of Utah Hospital, Baylor University Medical Center, Huntsman Cancer Institute, and Primary Children's Medical Center. Dr. Campsen's experience in both adult and pediatric care settings has given him a unique perspective on the challenges and opportunities in transplant across all age groups. His research interests are diverse, although recently he's turned his attention to two areas within transplant: the development of organ preservation devices that are aimed to improve the viability and longevity of organs during the critical period between donation and transplantation. His research also recently has turned to leveraging AI in organ transplant decision making, which you'll hear a lot more about today. He's done fellowships in adult and pediatric multi-organ transplantation at the University of Colorado. His medical degree was from the Eastern Virginia Medical School, and as a fellow of the American College of Surgeons and a fellow of the American Society of Transplant Surgeons, Dr. Campsen is widely recognized by his peers as a leader in his field. He regularly contributes to academic journals, presents at international conferences, and participates in medical education. He really is known for his commitment to patient care. He believes in a holistic approach to medicine, considering not just the medical aspects, but also the emotional and psychological needs of patients and their families. We're delighted to welcome Dr. Campsen today, who also enjoys skiing here in these beautiful mountains of Utah, including the summer outdoor activities that we're in right now. His passion for the outdoor activities really do further reflect his belief in the importance of a balanced lifestyle and physical well-being. Without further ado, we are delighted to welcome Dr. Jeff Campsen.
Thank you, Jacob. That was quite the introduction. I appreciate it. I was actually doing a donor surgery yesterday, and we procured 2 kidneys along with some other organs, and I wish that we had this available right then. So that's one of the reasons. It is very timely, and as we go through this whole talk today, it is something that I'm actively excited about getting my hands on and spread across the world of organ donation. So basically, we'll go into it. The problem. Do I switch this slide or do you all switch? There it is. Okay. The challenges that we have is just in the United States, and this doesn't include worldwide, which is much larger. There's over 100,000 patients waiting a kidney transplant in the United States. Out of all the donors that we have that come to donation and actually donate, 20% at least of the kidneys are discarded. Because of a variety of reasons. And one of the reasons are that there's a time constraint. So when the kidneys come out of the donor body and they're in storage and transported to the recipient for the transplantation, there's a short amount of time. And any delays in this can cause that time to go further and make the kidney not viable anymore. And the biopsies basically can delay these acceptance decisions and increase the time and increase discard rates. So in the literature, biopsies results are the most common reasons cited for why transplant centers decline kidneys. So it shows you the gravity of getting an accurate biopsy in a timely fashion. Even though I just said that, there's actually no standardized approach to how biopsies are performed, interpreted, and or reported. This inconsistent criteria for viability is a real hindrance. There's sort of an unwritten agreement that somewhere around 20% of sclerotic glomeruli defined on the biopsy is a reason for turn down criteria, but that's not consistent. And also, there is no true standardization in how the slides are prepared and how they're processed. And then finally, there's not a lot of renal pathologists that are familiar with organ donation available at all times, at all hours across the United States. And so this is a real hindrance to getting accurate biopsy results. So just a quick refresher for how things work. OPO stands for Organ Procurement Organizations. So there are about 54 OPOs across the United States, and they each have an area. And when someone is deemed having a non-survivable injury or meets brain death criteria, the hospitals call the OPO, and then the OPO goes, meets the family, meets the donor, and organizes the procurement surgery. They also then call the pathologist if they're available, and they also help prepare the slides. The slides then of the kidney biopsies, most often the kidneys are taken out of the body and they're biopsied on what's called the back table. They're wedge biopsies. Because of the rapid nature of organ donation, the best that we can do is get H&E slides, which are pretty good. They're the red and blue slides that people see. And they allow us to look at the glomeruli and the arteries and a few other details. It goes to the pathologist. The pathologist can read it. Some of the advancements with companies like Techcyte has been to where all of this now is uploaded digitally. And then these digital interpretations and even the slides can go to the transplant centers. Eventually, it makes its way to the transplant surgeon or the transplant nephrologist that then takes all the information, including the biopsy, and determines whether or not they'll accept the organ. And if the organ's accepted, it then goes to the transplant center where the patient gets their transplant. So this is our workflow. I think, Dr. Chen, this is where you take over the baton.
Yes. Thank you so much, Dr. Campsen. And like you've mentioned already, Techcyte has solutions to help really digitize and streamline this workflow for both pathologists and transplant surgeons. And thank you so much for walking us through all the critical challenges that are facing kidney transplantation today. And with that context in mind, I really like to share how Techcyte is really working to address these issues through our AI-powered digital pathology solution. So first, I will just give a brief overview of our process. So this is the digital workflow superimposed onto the transplant workflow that Dr. Campsen just shared. If you're not familiar, Fusion is our digital pathology platform meant to streamline and really augment pathology workflows. And if you're interested in learning more about the solution, we do have a few webinars that have been previously done to go over the different features. So for kidney biopsies for organ donation, what happens is after the biopsy samples are taken, they're scanned in by the OPO coordinators using a whole slide scanner. And then these images are then uploaded to the Techcyte cloud, where our AI will then analyze the slides. So the AI will detect, annotate, and enumerate all the glomeruli and help distinguish between the normal glomeruli and the globally sclerosed glomeruli, which Dr. Campsen had mentioned is an indicator of kidney viability. And then our AI can also identify the other entities as well, like arteries and arterioles. So then these results are presented to the pathologist on our Fusion platform. And the pathologist can review the slide with more confidence, as well as be able to verify the AI then to generate the report. So this is a look of what our model and our product looks like. So as you can see here, we have both the full slide image and the gallery of findings. And this can really help assist the pathology in having an efficient review of the case. And then each glomeruli will be clearly labeled and categorized, and this will save time and reduce uncertainty. In addition, the case can be shared in real time with other pathologists for a second opinion, and thanks to in-app collaboration tools. And this is a really great advantage because these biopsies come in at all times of the day and of the night, and sometimes the renal subspecialist is not the pathologist on call. So being able to allow for more subspecialty consultations, remote consultations, can really help give the pathologist who is on call a lot more confidence in their assessments, even when they're faced with more challenging or unfamiliar cases. So some major key benefits, this really affects all the major stakeholders in the kidney transplantation process. So like I've mentioned for pathologists, this can really help reduce the task of having to annotate and count. And again, a lot of times this comes at like odd hours at 2 or 3 a.m. and just being able to count glomeruli at that time of night, you can imagine it's a huge mental load. So being able to alleviate that burden is something that we find to be very valuable for our pathologists. And another thing is expanding access to telepathology. I feel like this affects pretty much everyone here on this list as well. And for OPOs, this can help expedite donor organ evaluation process. And then also through telepathology can connect pathologists with OPOs and sites that previously may not have good access to pathologists. For transplant surgeons like Dr. Campsen, being able to access reliable pathology results will give them confidence in being able to transplant the best organs for their patients. And just having consistent annotated pathology reports will also build trust between pathologists and the surgeons as well. For patients, this means a higher likelihood of receiving viable kidneys faster because now we have a more standardized way of being able to evaluate these slides. And also we have more access to pathologists. So patients who may be in more remote sites without access to pathologists can now still get a pathology review. And from a public health standpoint, just being able to increase utilization of viable kidneys is so essential given the ongoing organ shortage crisis that Dr. Campsen had mentioned before. So now I would love to talk about our project. So this is to assess the impact of our solution. Dr. Campsen collaborated on a study with us that was recently published, which we can share the link for the publication as well in the presentation. And we focused on utilizing our AI tool for frozen kidney biopsy evaluation. So a little bit about our study design. So we began with a data set of around 60 H&E stained frozen kidney biopsy slides that were retrospectively collected from donor kidneys. For our ground truth, we did have a board certified renal pathologist manually review and annotate each slide, and specifically marking the glomeruli and classifying them as either normal or globally sclerosed. And this was our reference standard for subsequent analysis. So then we recruited 2 independent reviewers to evaluate the slides. We had one general transplant surgeon who is not a pathologist by formal training, but is familiar with reviewing biopsies in the clinical setting with pathologists. And then we also had a general surgical pathologist who did not do a renal pathology subspecialty training, so they have limited renal pathology experience. And this setup is meant to be intentional because we really wanted to simulate a real life scenario where, specialists of varying levels of pathology expertise may be needed or on call to interpret these kidney biopsies. And then we really wanted to not only evaluate AI performance, but also to assess how much AI could help non-specialist viewers make confident, consistent, and accurate decisions. So moving on to our study design. So our study was designed in 4 phases. So the first phase is the manual digital review. And again, all of this is happening within our Fusion platform. So both of our reviewers reviewed 45 randomly selected slides on our Fusion platform without any AI assistance at all. And then there they were able to manually identify and count both the normal and the globally sclerosed glomeruli. And then we did a time study. So this was phase 2. So we had another 15 slides that were reviewed under the same manual conditions, but this time we had our readers record the time in order, the time it took to complete their assessment for each slide. We then had a 2-week washout period, and this was to minimize any recall bias. And then we brought in the AI assistants. So phase 3 is where we brought in the AI assistants. So there are AI annotations that are now available and presented to the reader. So the reader was able to see the AI labeled gallery view with pre-labeled glomeruli that were both normal and globally sclerosed to help guide their assessments. And again, this is AI assistance, so not AI actually deciding the final outcome. And then lastly, in phase 4 was the AI-assisted time review. So this time, the reviewers were able to measure the time it took for them to review 15 slides, but this time using AI assistance. So then throughout the study, we assessed the accuracy and concordance with the ground truth, which was our renal pathologist read, our time savings from AI assistance, and then we also wanted to take into account inter-rater variability and any bias that may or may not have been introduced by our AI. So we're excited to share the results from our study. So the first one we'll share is perhaps most immediately impactful is time savings. So the result was the reduction in time required to assess each case. So we saw that with AI-assisted review, both the pathologist and the surgeon were able to complete their assessments significantly faster, with time savings of averaged around 55% reduction. So for the surgeon, the time dropped from 30 minutes to 15 minutes, which is around a 50% reduction. And for the pathologist, the review time decreased from 4 minutes to just under a minute and a half, which is around a 62% reduction. And these gains are particularly meaningful in the real life setting because these decisions are really time sensitive, because the organ viability is very important when you're trying to transplant these kidneys. And again, these are also often happening outside of work hours. So any time savings is critical for pathologists and for surgeons as well. The next one would be for accuracy. So we looked at diagnostic accuracy, so particularly how well the reviewers agreed with the ground truth that was established by the renal subspecialist. And again, we used the 20% globally sclerosed glomeruli cutoff, which is a critical threshold for determining transplant viability. So with AI assistance, the reviewers achieved a 98% agreement with the expert's ground truth. And again, these are not renal pathologist experts. We have a transplant surgeon and a general pathologist. So both reviewers were more likely to correctly classify organ via viable or non-viable based off of this threshold when using AI. So this is really important because AI just didn't help them work faster, but it helped them make better decisions, especially when navigating more unfamiliar territory like glomerular pathology. So the next one is with consistency. So we measured inter-rater variability. So basically how consistent the two reviewers were with each other. So with AI, we saw a marked increase in concordance between the surgeon and the pathologist. So in other words, the AI really helped bring their assessments to closer alignment with each other and with the expert ground truth. So this reducing variability means more reliable and reproducible results, so regardless of who is reading the slide. We also evaluated for systemic bias in the reviewer's assessment. So we wanted to make sure that the AI wasn't skewing the reviewer's decisions in any direction, but instead acted as a consistent and unbiased assistive tool. And we found here, you can see with this Bland-Altman plot off to the right, that there was no evidence of systemic over or underestimation of glomerular sclerosis by either of the reviewers using AI assistance. So I'm just going to quickly just summarize from the pathologist point of view. For us, this is a great advancement, a great tool to have. Again, it just really reduces that cognitive burden of manually having to identify and count glomeruli. And then it can also really help us streamline the entire diagnostic workflow and give us back some time as well when it comes to evaluating these slides. And also, lastly, will give us a lot of more confidence, given that there are a lot of non-renal pathologists who will be evaluating these slides. So even with generalists without renal subspecialty training, they can feel rest assured that they're making the best decisions for their patients. And then I would love to turn this over to Dr. Campsen to hear about the impact for transplant surgeons and for his patients with a tool like this.
Thank you. So I'd like to say this was a really exciting study to be part of, because it is so impactful, and it's something that is really going to change the workflow of organ donation, as well as increase organ donation. I think what Dr. Chen pointed out, the reduction in time is very important. We do have a lot of different modalities to increase time with kidney pumps and different organ preservation devices, but still, the faster you can do the transplant and the more accurate of the matching that you can do, the better. And this reduction in time is super significant. If you noticed the difference between the surgeon and the pathologist, just the overall times, were very different. And I think that's because you just have different levels of training, and we don't know what we're going to get at the time of donation. And the AI assisted really helps with that. It basically does a lot of the dirty work, so the pathologist can really practice at the top of their license. I also think that it starts to move us towards more reliable decision making. There is already starting to be regulations that are adding to on top of OPOs and transplant centers on what should be biopsied absolutely, and that's increasing the number of biopsies going forward. And with this, everybody needs to change their workflow and be more accurate and more consistent. And I think this is this tool is going to help with that dramatically, because it over and over again. And what it does is, I also think it allows to build trust between different organizations. So transplant is no longer a local industry; it is national. Organs are going to the best match patients all over the United States. And most of the time, centers haven't worked with each other before, or if they have, it's been thin. And I think this sort of underlying tool allows for trust, that allows for even more rapid understanding of how things are done, and allows for organs to be accepted more rapidly. And then, of course, this is the tip of the iceberg, if that's the right thing to say, where we're going to continue to train this model, so it broadens its expanse and becomes even better. This is the paper that we wrote and was published. You can find this on PubMed. We're really proud of it. It describes everything that Dr. Chen went through in detail, how we did everything. And again, there'll be a link to it. And there's a lot more pictures in it too. Future directions. Let's see what the future directions are. What I would like to say here is that there's a lot of different parts to the kidney. The main return on investment is really the glomeruli, but we need to get better than that. So we're going to look at fibrosis of the kidney, arterial damage, which is the one I'm most excited about, because I think as these different individuals have hypertension or different things like that, looking at the viability of the arteries goes along with the glomeruli. And then, of course, inflammation. Many of these donors have gone through quite the ordeal to get to donation, and inflammation is very important to understand. And then there's cutting edge technology on different types of genomics and DNA and things like that. And as slide preparations change, we can adapt our model to also potentially program into these new changes. So other organs, it's interesting. Someone asked me this last night, what can you donate? And you can donate all of these. This is basically what we're calling solid organs, and including intestines. But there's also tissue donors, and that includes skin and bone and eyes, tendons. And I think that pathology can be expanded to a lot of these also. So it's very interesting, once we have a tool, where that tool will be useful.
And then while this study mostly focused on like kidney transplant biopsies, and like Dr. Campsen said, I think the potential for AI to really affect and help streamline workflows for other organ transplants. We did want to talk a little bit briefly about like implications in pathology that extend far beyond organ transplantation. So just across the board, we saw that here in kidney transplant, but AI really has that potential to reduce pathologist fatigue. So they can help automate just repetitive, time-consuming tasks. So these can be things like counting glomeruli, which we saw in our study today, but also things like screening for mitotic figures, quantifying stains, or even disease detection. So by offloading these routine tasks, the AI can allow pathologists to really focus their expertise on complex decisions that really require human judgment. In addition, AI can increase diagnostic accuracy and consistency. So we saw that today in our study too. And particularly in areas that are prone to inter-observer variability. So something like counting glomeruli is an example of something with high inter-rater variability, but other things within pathology like grading dysplasia, identifying metastases, or even assessing margins can be very variable across different readers. So it really just helps act as a second set of eyes. And lastly, one of the most powerful promises of AI in pathology is the ability to really democratize this access to subspecialty level expertise. So in many settings, especially in smaller hospitals, rural areas, or even during off hours, cases are read by pathologists who may not have that exact expertise or exact specific training in subspecialties like renal or hematopathology or dermatopathology. So this can really help, or this can introduce variability and delay critical decisions. So we really believe that these are challenges and gaps that AI can really help bridge. So that brings us to where we see Techcyte's future. So Techcyte is really committed to driving meaningful innovation in pathology AI, and not just with individual models, but with a true integrated and unified approach that spans across the pathology spectrum. So as we continue to refine our AI models to go beyond single task performance, our vision is really to support multimodal analyses. So bring in things from like H&E, from IHC, clinical metadata, and molecular results to get deeper and more context-rich insights. We also want to develop tools for both, anatomic pathology, like with kidney transplantation evaluation, but also within clinical pathology, which we do also have a whole portfolio of products there as well. And then by embedding expert level AI models directly into a digital pathology platform like Fusion, we can really help bridge gaps in current care workflows. So AI becomes more like a real-time assistant that can really support pathologists and give them more confidence. So this will not only raise the baseline of care for all institutions, but also, enable more equitable access to high quality diagnostics, regardless of geography or resources. And ultimately, we believe that AI is not about replacing the human pathologist, but by amplifying their impact by allowing for faster, more accurate, and more equitable diagnostic care. So this is all building on our single unified platform, Fusion. And hopefully you can see how this is, one part of Fusion that can really help streamline this clinical workflow that is typically quite challenging, and really also streamline reporting and drive more informed decision-making. So let's just bring it all together now. I know Dr. Campsen has a few other maybe more interactive activities that we can share with the audience today. So turning it back to you, Dr. Campsen.
Thank you. So we have a little poll. This is basically, last night I was in Idaho performing a surgery, and we actually took the liver, the heart, and the kidneys. So based on all these other different organs that we talked about, I'd like to see which organs the audience thinks would be the next that we should look into. And go ahead, and I think you have the ability, Jacob, to press a button and do the poll.
Yeah, we're getting some responses right now in real time. It's live. This is fun. Right now, liver is leading, but heart's right behind. So you took that many different organs in that one last night, huh? Wow, you said.
And this is a good example because this was an older donor in their 70s, and what we're basically seeing is that all the organs were biopsied to some extent. And in this particular case, there was not a pathologist available. on site, so everything had to be transported out digitally, but also with the organs back to the centers. So this is real time. Why we're doing this, why we need this, to really help facilitate getting all the data so that we can basically have the best organs go into the right patients.
Wow. Okay, I'll go ahead and end this poll. Yeah, it looks like there's a little more in. Yeah, liver's going to win this one. Interesting to get the feedback from the audience. Let's see, we'll show the results. And then I think you've got another question. Is that right? See their input? Oh, and here you've got a comment that liver might be next, huh?
Right. So what we would like to look at next is liver. So the difference between organs is vast. And with liver, as far as relation to organ donation and transplant, it's the amount of fat that's in the liver. And if there's too much fat, the liver won't actually be able to be transplanted. And reading fat is a percentage of the total volume of the liver. And so when we get a biopsy, it's extremely difficult for a human to really count every single globule of fat. And I think superimposing AI, the fusion model on top of this to assist the pathologist is going to be a game changer. I think it'll help with time, but I suspect the concordance and the accuracy is going to really compress, and that's going to be very helpful. And again, it's going to create trust amongst centers, that you can really rely on the data and accept these organs. So basically, the key takeaways here are what we've been talking about over and over again is that we improve the speed, which is super important in organ donation. But more importantly, we also increase the consistency and accuracy amongst different types of individuals and team members. And this creates an environment of trust, which I think is hugely important. And it has the potential to transform organ allocation, and it has broad implications for pathology, allowing for, again, the best information possible provided to the transplant centers. Coming up next month, we're going to also present this at the World Transplant Congress. This is the leading conference that encompasses the entire world. And, you know, we're very focused in on the United States, but there are incredible transplant programs throughout the world. As well as, unfortunately, disease is not nation state dependent. It goes across all borders. And we think that this is something that can help the entire world. And I think, again, when you're dealing with supply and demand and a shortage of available organs and people dying on the wait list, we can't get this out quick enough, is my opinion.
Yeah. And thank you so much, Dr. Campsen, for, you know, working together with us on this. And I feel like this really aligns really well with our Techcyte mission and our values. And we believe that the Fusion platform together, you know, with pathologists, with surgeons, we can really help innovate within the field of transplant and help give, you know, better access to these organs and better outcomes for our patients. So we're really excited to be part of this whole movement. And with that, we would love to hear your thoughts and questions, how we can, you know, continue to share and shape the future of this space together.
Dr. Campsen, Dr. Chen, thank you. Really fascinating stuff. Just thinking about what you were doing last night in Idaho and just how pathology AI can help with all those and the ripple effect across states and countries, to your point. Let's see. We won't have time for all of these, so I'll just prioritize a couple. I think this would be interesting. How long did it take for those who were using a solution like this to get comfortable or be up to speed with the new tool? I know you both were in the study. We have customer pathologists using this today as well. What would you say around comfort level learning curve?
Yeah, I would say when we designed out Fusion, it was meant to be like very intuitive for all users to use, and we present everything in a very easy to view way with our gallery findings as well as with the whole slide viewer, and with our board certified renal pathologist who we had do all the manual reads for the ground truth. All we did was just a really quick training, and they were able to do it pretty quickly. I would say it's just really meant to be designed for pathologists who have, zero digital experience to pathologists who may already be digital right now. So the whole solution has been designed to be very user friendly. We'd love to hear from Dr. Campsen, who this may be, a new pathology solution that he's never used prior to this. So I would love to hear your experience too, Dr. Campsen.
Yes, this is great. So first, the digital platform compared to getting underneath a microscope and moving stuff around is super easy to use. But what's really nice is the, for lack of a better word, grunt work, which is identifying all the glomeruli, is immediately done, and that's great because when we are determining the percentage of sclerosed glomeruli, the denominator is as important as the numerator. And so the more that we can find, the better. And if there's, 150 glomeruli on one biopsy slide, you can imagine how long that takes. And there's a fatigue just from a human standpoint. So again, we talk about in medicine, practicing at the top of your license, and finding glomeruli are not necessarily the top of someone's license. What is the top of their license is looking at each individual glomeruli and determining whether or not they're viable or not. And that's what I want to know. And so this has really expedited the ability of our team members to give accurate reads. And again, like I said before, it's starting to build trust. And there's a lot of distrust in medicine just because there's not relationships when you're nationwide or worldwide. And this kind of uniformity, I think, really helps with that.
Let's take one more. And I think because of the diversity of our audience, I think a lot of us who maybe are more of a lay audience, we aren't surgeons or pathologists. We do have a few listeners that are in those roles, like you two. Kelsey asks, from a technical side for heart transplants, where in the heart do you biopsy, Dr. Campsen, and what do you look for?
So certainly, so the biopsy for the heart is often inside the heart. And so hearts don't get biopsied at the donor very often because it's technically difficult. There are starting to become new types of organ preservation that allow us to put hearts on the organ preservation machine, and then we can do different things and access the heart. But most often, so there's not bleeding on outside of the heart, it's done inside the vasculature of the heart, inside the chambers of the heart. And that way, if there is any bleeding, that's okay because that's where the blood is. So that's where the heart's biopsied.
And what are you looking for?
So basically the quality, so the heart is different than the other organs, right? The heart is basically a muscle and it's a pump. And you want to make sure that those muscle tissues are viable. The donors have gone through a unpleasant experience to get to donation, for lack of a better word. And we need to make sure that the heart is not damaged. there's a lot of things that we do. We do CAT scans. A lot of times they can do catheterizations to make sure that the coronary arteries are open and they look good. We do echocardiograms to make sure the ejection fraction, the pumping is good. And so each one of these things allows for an overall gestalt of whether or not this organ is going to work. And then we also believe that this is going to be expanded eventually to post-operative care. So hearts, for instance, get biopsied very frequently after transplant, looking for rejection. And that's another area that we're very interested in exploring, because rejection is the recipient trying to attack the graft. And you see that in different types of white blood cells. And again, those are so small in the degree of inflammation. And we talked about that in a little bit with kidneys, where inflammation is an area that we really want to start looking at. Techcyte's done a lot of work on blood slides. And so that data is already there. We already know what the cells look like. And to be able to superimpose that onto rejection is something that I'm very excited about.
Dr. Campsen, it's been Techcyte's privilege to have worked closely with you on this project, and for all of us as an audience to have had you on today's episode of the Pioneers in Digital Pathology series. We thank you again for your time and interest. We've all learned a lot today, and Dr. Chen as well. So again, thank you to all for your participation, engagement, and listening today. We look forward to catching you on our next episode. Again, have a wonderful day. Thank you.
Thank you so much.